Howdy, folks. So I recorded this. I actually did a more production style of recording this training because it really is like the vibes of this are very much a training. So I really wanted to find people that this is what they live and breathe. So what you're going to hear about today is perinatal mental health, and specifically that it was very much built and how we help people who are pregnant and people who are post-pregnancy. It was really, really built for neurotypical people. And it really leaves so many people out. So I recorded this back in June 2025. Well, it has been a lot in my household. It has been a lot in my practice, which, 2026 is a dumpster fire and we are living in fascism. It is what it is, and I'm getting out episodes when I can. So I appreciate your patience and grace for me and the people who help me get these episodes out. But I had the privilege of recording 90 minutes. So this is one of the longer ones with 3 clinicians who sit at this intersection that really can understand the neurodivergent and perinatal mental health intersection far better than me. I knew at that point, of course, that this conversation would matter, and it matters even more now in 2026. So perinatal mental health systems are often built around neurotypical people and assumptions. OCD in postpartum periods is often misunderstood. Intrusive thoughts are frequently pathologized without any nuance. Autistic and ADHD people or ADHD people are often misdiagnosed, undersupported, and shamed often. When we as people and clinicians do not understand neurodivergence in pregnancy and postpartum, we don't just miss diagnosis, we miss how people deeply experience things. So I want to briefly introduce our speakers. They're going to introduce themselves with their credentials even more in depth, but I just want to highlight Stacey, Jane, and Skylar. Stacey's background is in psychiatry, neurodivergence, and is incredibly passionate about teaching. She's a wonderful teacher. If you get to take a training from Dr. Greeter, you should. Jane is our perinatal certificated expert and sits in the private practice lens. And Skylar treats OCD, trauma, and does neuro-affirming care. Again, they're going to give you all of their backgrounds as this is a more presentation style. Brain is tired. I feel like constant fatigue is something neurodivergent people we deal with a lot, but with the world the way that it is, it's constant. It's like trying to get through mud up here. What you will walk away with: clear differentiation in OCD and postpartum anxiety, understanding sensory needs in perinatal care, how trauma complicates perinatal presentations, and a neuro-affirming lens that you can bring into supervision and into your practice. So I really hope that this gives you a deep dive into something that is so, so important. And I will make sure that you have all of their contact information. So if you want to see another training from them, you can do that. And let me know in the comments what you learned or what you felt like, if you've had this lived experience, what that was like for you. So without further ado, I will let these 3 wonderful humans take it away.
Hi, thanks so much for joining us. I'm Dr. Stacey Greeter. I'm a child, adolescent, and adult psychiatrist licensed in Florida and Colorado, hopefully Soon, Washington is coming down the pipeline, and I am really passionate about teaching psychiatry to anyone who will listen to me talk about psychiatry. I am autistic, ADHD, and OCD. So helping people understand neurodivergence better and thus um, create a better world for neurodivergent people and better treatment for them is my passion. Now I'm going to let Jane and Skylar introduce themselves.
Hi, I'm Jane Kosloff. I'm a licensed independent clinical social worker, and I also have a certification in perinatal mental health, the PMH-C. I am in private practice, and one of my big passions is the intersection of supporting neurodivergent clients and the perinatal period. So I'm really excited to be able to talk about that today.
And hi, I'm Skylar Ibarra. I am a licensed clinical social worker, PMH-C as well, in California. And my intersectional identity also includes autistic, ADHD, OCD, lots of letters, as well as audio processing. So sometimes if a word comes out a little wrong, Jane and Stacey might catch me because, sometimes that happens. And that's just part of my neurodivergence. I work specifically at the intersection of OCD, perinatal mental health, and complex trauma, all within the neuro-affirming paradigm. And that is really where my passion lies. And so I'm so happy to be able to share some of my deep, deep interests with all of you today.
And I did realize I forgot a few things, if it's okay.
Yes, Jane, more about
Yeah,
Jane.
I think I forgot to say I'm in Washington State and my identities. So I'm also autistic and an ADHDer.
On brand,
That's
though,
right.
to forget.
Also auditory
Yeah,
processing disorder over here too.
Well,
I didn't know that about you. Cool. Got it.
No.
Take two. And welcome to our presentation, Little Mermaid themed, Under the Sea, but Over My Head, addressing the unique needs of neurodivergent pregnancy and parenthood.
That's right. That was me. Sorry, guys. There's not a little light. The color wasn't there.
Well, I
Sorry.
think
So,
sorry that we can kind of go back and forth between on the next two ones. But yeah, I was going to let you jump in first.
okay, yeah. No, sorry. For some reason, I thought that was further on now, and it wasn't. And that's okay. That was on my own brain. So, when we're looking at the neurodivergent experience of pregnancy and birth, it is really different from, I think, a lot of neurotypical expectations in that doctors are expecting a neuronormative patient. And also, for many of us, especially those who are late identified, we may not have the exact terminology or wording or understanding of ourselves to be able to advocate in a way that is conducive to our needs. And so when we are supporting our clients or patients who are either pregnant, wanting to become pregnant, or processing their pregnancy and birth, oftentimes I like to almost think of it as experiencing a 3D movie without having the 3D glasses on. Everything is a little obscured and blurry. And then all of a sudden, as somebody comes into their neurodivergent identity, they're able to put these glasses on. And with that, there's the wow factor of, oh, things start to make sense and my needs start to make sense, or the needs that I had that I didn't know how to express before, it makes sense why I did not have those needs met. And then also with that, there can be grief. Wow, had I known this, I would have had a different outcome. I would have had a better birth, a better pregnancy experience. I would have advocated for myself and my child better. And then hopefully as we are able to continue on in the process, there can also be meaning making. And we know that that is so important within traumatic processing and being able to kind of come to the other side of that. And for even people who do understand. So when I was pregnant with both my children, I knew I was ADHD. I did not know I was autistic. Fortunately, I had connected with a neurodivergent midwife. I have my kind of superpower is just finding the neurodivergent people and I am able to attract them and we stay together. So even with that though, and her being so understanding, there was definitely parts of my experience where because I didn't understand my ADHD except through the medical model, I had a very different experience had I understand myself, not just that I was an ADHDer, but what that meant through the neuro-affirming model, that this was a part of me, a part of my intersectional identity, and not some sort of disorder that I had to work to lessen the impact of. And so while we're working with people, regardless of whether or not they understand their identity, I think it's also really important that they understand their identity through a neuroidentity lens, and then being able to work out not what do other people need in their pregnancy or birthing experience, but what do you need? And if we're looking at a previous experience, being able to provide that compassion and tenderness for what they didn't know, and also being able to really bear witness for the things that they could have had and because they didn't, that caused harm.
And I'll just add in
Yeah.
quickly that it's part of why I really enjoy supporting neurodivergent folks during this time period. It's already a phase of so much change. It's already a phase of identities shifting, whether it be into parenthood, whether it be one child to two, but also it can be this really rich place, especially with support, to be exploring, again, neurodivergent identity from an affirming lens. And combining all that can be such a powerful thing to be a part of and supporting folks around.
Mhm.
Um, as a perinatal reproductive psychiatrist, who also specializes in neurodivergent population, I really want to challenge clinicians to be as humble and curious as possible because even me being autistic myself, their experience and their needs are going to be different than mine, and to be more explorative than prescriptive throughout the process.
The quote, if you've met one autistic person, you've met one autistic
Yeah.
person, that I think one of the things to keep in mind is that as a provider, it is going to take more work to be able to provide competent care within the neuro-affirming frame. And I think when we are working from a neuronormative lens, there is a shorthand and ease. But regardless of the neurotype, even for a neurotypical person, there is still so much opportunity then to cause harm without that curiosity, without that non-hierarchical practice, without truly joining and understanding the person you're working with, and then tailoring the experience of their treatment to who they are as an individual. And that is something that most of us are not trained to do within our postgraduate work or graduate and postgraduate work. And so being able to really challenge ourselves as providers, because I can say that even though at first it was a lot more work, the work I do now is so much more satisfying. It feels better for me as a provider, and my clients know the difference. Most of them have already been in a pathology paradigm level of care for a very long time. And every single one of my clients will then come to me and say, there is a difference here. And so, as we're really allowing for that, if that curiosity piece throughout all of this, knowing that individual needs may differ from the norm, and that is not pathology, that is not something wrong that we have to bring the person towards this mythical center, but instead, how do we adapt our own understanding and our own tools to be able to meet that person's need?
Highlighting also very important and underserved, less understood by medical professionals, the transgender pregnancy experience.
And this is again, I think I do want to own that this is not my lived identity. And there are people who, if you look up seahorse dads, there's a lot of non binary parents who do share openly and so generously their experience on social media. But that said, if you have a client who is in any way gender nonconforming or trans, that is a part of their experience. And that is an opening to also within, especially now for those who are in the US, a lot of stigma and trauma and mistreatment. And so, as we are going through that process, being able to ask those questions and also finding the places of joy, finding the place of connection. What is it like to be a seahorse dad? What is it like to be a birthing parent? And how does this change your experience when to create your own identity? Because that is also a really beautiful, empowering place. And so, whenever we're working with people who have been or are being harmed by the greater systems, I think we have a tendency to go to how are these systems harming you? Because that is how, again, we've been trained. But when we're looking at holistic experiences, what are the joys of being able to come into parenthood truly within your own identity? What is that like for you? What is it like? What are the traditions you're creating? What is the community that you are creating? And how is that then going to overflow into the rest of your identity and your experience and your family? And can we create, the not create, I think it's already there, but can we really bask in the joy of that alignment?
Anything you want to add on this, Jane, before we move to our next slide?
I think Skylar, I think
Cool.
I think got to it. Yeah.
And just being mindful of the um, trauma that some of these patients experience while interfacing with a non-affirming medical system, and at the same time experiencing increased gender dysphoria at times due to needing
Hmm.
to stop gender affirming hormones during the process. Um, and um, Holding a lot of space for them to process their experience.
Hmm. I
Thanks.
always like to say that our experiences aren't an equation, right? And so I think we as human beings have a tendency to want to add the good with the bad, and or especially when it comes to children, a lot of people feel pressured to manipulate the outcome where it's all worth it. And
Mhm.
when we can back up and just say there are these things that are traumatic and these things that are positive, and they don't have to be balanced against each other. They all are true, then that creates so much more space for processing gender dysphoria while you want to be a parent and you work so hard for this, right? A lot of trans parents will have a much more medicalized birth and um, pregnancy experience. And so being able to hold that, like, that's really hard and you wanted this. You don't have to decrease how hard it is. And we see this a lot with any parent going through fertility treatments, right? That you could have worked really hard and pregnancy can still suck. And it can still, and trauma happens and all this. It doesn't have to fit into one tidy narrative because it's not tidy. And that's okay.
So, which brings us to our case. Ariel. So, Ariel is a 25-year-old, comes to you 24 weeks pregnant. This is Ariel's second child. She is cisgender, and her diagnosis ADHD, autism, and PTSD from complex childhood trauma. Current medications, Concerta, stimulant, and guanfacine, 3 milligrams. And she came to her autism diagnosis after the birth of her first child. And with their diagnosis, started to explore her own neurotype, which is commonly the case that we are seeing these parents diagnosed after the diagnosis of their child. And is now going to process this with her clinician as she prepares for her next pregnancy.
And when Ariel first started bringing this up, when she was really relating, as she was learning more as her child kind of went through that process, she got some responses that were well intentioned but not so helpful. like, oh, you're so high functioning. You don't look autistic. Um, but that was really not looking at what Ariel's experiences really were, beneath the surface here, beyond just kind of what the doctors and therapists were kind of, I don't know, seeing on the outside maybe.
Seeing it, or it's surprising to you when your patient brings up that they might be autistic, be curious. Looking beneath the surface. Now, she tells us that initially, with the first pregnancy, when she was struggling a lot, she was diagnosed with depression and anxiety. She says, my therapist said I struggle with being a mom with my first child because I lost my mom when I was so young, attributed it to trauma. My OBGYN said I was having anxiety about being a mom and struggling because I just needed a higher dose of sertraline for my anxiety. No one even considered I could be autistic or ADHD until the diagnosis of my daughter, Melody. I never belonged under the sea. I thought it was because I was meant to be human. But I didn't really belong on land either.
So Ariel had an image of what she thought motherhood would be like, partially of just what she always kind of thought, also social media and TV and movies. So she was thinking it would be like this instant connection and there'd be hard parts, but it'd be really blissful most of the time. And then for her, actually, especially the beginning, that there were a lot of parts that were really challenging that she was just not expecting. And it was really hard to have that difference of coming in with this image and then what the reality was, at least at times for her at the beginning, were just not matching.
And so while she was discovering her own identity and looking around and going, wow, this is not what is being modeled for me. The only thing that Ariel was able to come to is that she was an inadequate parent, right? You're just being dramatic. You'll get used to parenting. You're so selfish. When she's looking out for anyone going, this is really hard. My chat, oftentimes autistic parents have autistic children. I'm doing the things that I'm putting them to sleep on their back, drowsy, not asleep, and all of a sudden they just wake up again. And no matter the only way that my baby will go to sleep is if I'm holding her. Well, oh, you're just not doing it right. Right. Oh, well, whenever my baby cries, it's so hard for me. I actually shut down instead of being able to go to her, even though I so desperately do. I feel like I'm frozen. Well, it's hard to take care of kids. You'll get used to it. You should just enjoy it. Just enjoy the thing. Don't worry so much. And all in all, and so everybody's, again, well-meaning comments of trying to normalize her experience instead invalidate and minimize the very true experiences she's going through.
These autistic little ones often have very different sensory needs, sleeping habits, feeding habits, and her experience as a mother is different. And it is
Mhm.
so easy for people to judge from the outside, unfortunately.
Yeah, and there can be assumptions around that if a baby isn't responding a certain way, and I think it's an unsaid, not always even fully thought about assumption that the parent must be doing something. That, like, what is going on with the baby is just a full relation to, like, I don't know, not following a recommendation versus really looking at that this just might be a different experience that's hard.
So you can just see all these moms and babies who are just cooing and loving on each other. And one of the big things is that Ariel's only seeing these parts where they're out and they're out of their routine and showing, but um, we don't know what's happening on the inside for any of these families. And one of the big things that I'm really interested now is the different forms of empathy. And oftentimes, autistics have very high emotional empathy and fairly low cognitive empathy, meaning that I'm around my friends and I can feel that in these moments they're happy. Maybe it's just because it's the first time that they were able to shower and get out of the house in a week. And so feeling that right. And then also I'm seeing all of my friends with their connected to their babies. And I know that when I'm home, I'm not like this at all. And so then the idea that maybe they could be struggling in other ways when they're not in the here and now is I can know, like for myself, hi, I'm Ariel, right? It was really hard to go, oh, but I know what I'm going through. And then it wasn't until I became closer to some of my own parenting friends when they were giving me feedback of, oh, wow, but you're so connected and you're doing all these things right. And I was like, wait, what? No, you're the one doing it right. And we were able to get to that deeper level again, because of my amazing and I feel so fortunate and lucky ability to find other autistic moms very early in my parenting experience. Literally met them in prenatal yoga, and we are still friends to the day. And none of us knew that we were autistic when we were pregnant and going through postpartum together. And now all of us identify that way now. Two of us because our kids are identified autistic, the other one ADHD and audio processing disorder. And so all of us are also realized that our kids needed different stimulus. Our kids needed that. And so one of the things that for me, I felt that, okay, my child was one of the easier children in my parenting group. He was still waking up every 2 hours, needing to nurse all the time, very particular sensory needs, very sensitive skin. It was a lot of work to keep him alive and to keep him like regulated, but he was still the easiest baby out of the bunch. And so that actually led to even greater feelings of inadequacy for me, because if I have this easy baby and I'm still struggling this hard, then it must be my fault. Not knowing that, oh, my son needed a lot from me and I was giving a lot to him, but it was hard for me to see that at the time.
We're helping these parents with the self-comparison to neuronormative standards is really key in the work
For
with their
sure.
clinician. And
Yeah.
so, prior to an autism and ADHD label, with that self-understanding, there were a lot of unhealthy labels that Ariel was getting, both from outside and from within. When she didn't understand how to respond in a particular situation, she was told she was rude, overly sensitive for feeling feelings even more strongly, way too intense with her interests in collecting human artifacts, selfish, maybe just a bad mom she internalized. And then embracing and affirming identity, understanding autism and ADHD, she started to shift her perspective on herself. She says, instead of trying harder at things that don't work for my brain, I can embrace my strengths and vulnerabilities. A neurodiversity affirming identity regarding autism and ADHD does not mean that we're only recognizing strengths or talking about autism and ADHD as superpowers. It means that we have a balanced perspective, that this is both a blessing and a curse. There are things that are going to be really easy for her brain, and then seemingly simple things like remembering an OBGYN appointment that will be hard.
And I think the big thing is that just because it's easy for other people doesn't mean it's easy for you, and that's valid too. What's simple for some people are just genuinely hard for others, but also, and again, this is where we start to, oftentimes the strengths deficit conversation is around a neuronormative standard. And when we instead break from that linear perspective and go into a diversity mindset, then we can say, okay, what is easy for you and hard for you? Instead of where are you excelling and where are you failing? And so if somebody says, yeah, I should just be able to remember my appointments, then being able to say, well, some brains do. Some brains are just made to keep on track with other things. And so, with that true, then if that's true for you, what are the supports? What are the accommodations that you need to be able to get to your OBGYN appointment? What do you need to be able to remember to feed yourself, feed your child? If for those low interoceptive babies who go from content to completely starving in about 3.6 seconds, and so you're not seeing those cues from the babies as well. What are other ways that you can start to set timers and start this and that doesn't make you less caring or less able parent? That actually just provides the supports and accommodations you need to be an aligned parent with your values. And when we're able to shift that and we're not, again, that good, bad, strength, deficit mindset, instead, what do you need? And that's really understandable that you would need that. Then oftentimes the compassion starts to really grow. The curiosity is able to start to flourish, and parents can find what it means for them to be a great parent instead of comparing themselves to this great parent archetype that doesn't even exist.
And I do want to mention that that some of that because like the perinatal period is a vulnerable period for a lot of reasons, there can feel like a lot of pressure. That some of those older sort of beliefs or messages that people have received sometimes do get louder during those time periods because of like whether it be external or internal pressure around wanting to be a good parent.
A lot of clinicians, if a mom is doing pretty well, she's fairly successful per neuronormative standards, should we diagnose her? Should we tell her that we suspect that she's autistic or ADHD? An accurate understanding of one's neurotype provides accurate self-knowledge and helps shift that label from character flaw to my brain is different. These are some awesome things about my brain, and these are some real vulnerabilities, which enables greater and deeper self-compassion and then freedom. There's a quote that I'll read that I love from Is This Autism? A Guide for Clinicians and Everyone Else by Donna Henderson. There's also a companion guide for diagnosis. Only accurate and neurodiversity affirmative self-understanding can free an individual from a lifetime of self-blame and shame. Countless autistic individuals have beautifully expressed the freedom and validation they felt when they were finally recognized as autistic. For many, understanding themselves through this lens has enabled them to experience less emotional distress, engage in better self-care, feel a sense of community, and advocate more effectively for their needs. This is an example of an ADHD screening tool. I do not base a diagnosis ever on a particular screening tool. It really helps open up the conversation. The gold standard of diagnosis is really a detailed clinical interview where I invite the patient themselves to learn more about autism and ADHD and tell me what fits them and what doesn't fit them, to engage them in self-exploration. The RADS-R is a great free, again, screening, not the be-all and end-all of the diagnosis tool as well for autism that is available online and Embrace Autism.
And one thing I like to mention with the RADS-R is that it has a very high true positive rate. So if it says you're autistic, you're very statistically likely to be autistic. However, it also has a high false negative rate because for many people, they're so high masking that it is not in the level of consciousness of that certain things are hard. I know for me, the first time I took this, I took it from my masked self. And so I interpreted a lot of the questions very literally. And I thought they were asking me, can I? Not, is this natural for you? And when I started really being able to challenge myself and challenge um, where my mask was and what really was taking energy from me, what was creating anxiety for me, and I took it again, I had a wildly different score. And I also understood the question, it was like, again, that like putting on the 3D glasses. And I was like, oh, that's what they were asking me. I couldn't even comprehend what they were asking me the first time I took it before I really understood what autism was and wasn't. So I like to oftentimes, always when share the RADSAR, kind of put that out there to my clients, because sometimes before I really understood that about the RADSAR, I had some clients come with feeling very um, almost ashamed. Oh, I thought that I was autistic, but look at how low my score is. I thought that this was going to be really validating, and instead it was very invalidating. And so now I just kind of prep my clients with the idea of think about one of you a bad day in a bad environment with people you feel comfortable with. And for a lot of these, because that's oftentimes when our mask is our lowest. And again, being able to do it, use this really as a platform for questioning and being able to then have conversations around these questions versus just creating a Likert scale and deciding if somebody is autistic or not, like from that, like Stacey was saying.
So, speaking of masking, I want to go into that just a little bit more. First, to give a little bit of a definition per se, that one way to think of masking is it's hiding or suppressing. In this case, if we're like neurodivergent traits, yeah, and that can be something like Skylar was mentioning, like with the example that she gave for her, that some of that, like sometimes that is not something that is so conscious. Sometimes it is. And sometimes they are such long patterns that it is not something that people are thinking about as something that they are doing or, again, are aware of. So I'm going to give a few examples for Ariel around how masking shows up. So she has a really deep passion, right, for human artifacts and has a collection. And she loves spending time there looking at her collection. She really enjoys talking about that. But potentially she may have gotten feedback from friends around there may be this message of she talks about it too much. That may be like, hey, we're tired of hearing about that. Let's talk about something else. But the artifacts again. And so she may have at some point pulled back on how much she talks about it, even though like she is just as interested and gets such joy from talking about it. And then she may also pretend to be more interested in other topics that her friends are talking about. So again, masking can look all sorts of different ways. Can involve facial expressions, clothing, like sometimes it's trying to wear certain clothes, either for trying to look professional or wanting a certain look, but maybe those clothes are uncomfortable or not really expressing the style that it feels more authentic to them. There can be ways of changing speech and body movement, um, discomfort, and that can be that sometimes neurodivergent folks can get messages around like how they express feelings. And so some folks may learn to kind of tamp down like certain emotions or not show it in certain settings. And again, sometimes people realize they're doing that and sometimes not. And I do want to really highlight, again, there's a lot of nuance to masking, but it can also be a matter of safety. And especially for marginalized populations, BIPOC folks, other marginalized folks, that there may not be that room to act differently and that still be a safe situation for them. And in the perinatal period, masking can come up in all sorts of ways. For some folks, they may find that they're masking more to try to kind of fit in with parent culture or wanting to kind of be viewed a certain way. And I definitely have worked with folks where postpartum, they go into burnout and they talk about that they just can't mask anymore. And they don't feel like it's a choice. And that can be a big change if that's something that they went through the world one way and that's not accessible anymore. That can also be a big change. So yeah.
I saw this question up on Facebook just today. It was, well, if everybody masks, why is it a big deal? Autistic and ADHD people masking. And I think the point that everyone masks their authentic selves to some degree is valid. But when an autistic person is masking or an ADHD person is masking, they're simultaneously expending a lot more cognitive energy to figure out what's expected and what people need from them, and suppressing their primary sources of emotional and energy renewal, such as talking about special interests or stimming. So, the emotional and cognitive toll that masking takes on a neurodivergent person is much, much greater than on a neurotypical, the unseen autistics.
And so with this, oftentimes when a clinician, especially one who does not understand neurodivergency beyond the DSM, they are basing their understanding on that male and pale, right? The white, middle class, adolescent boy who was studied in the 50s and what that looks like to be autistic, to be ADHD. And so women, genderqueer folks, trans folks, people of color, right? Anybody within a marginalized community, oftentimes kids who are raised in a different culture, are then going to have those same characteristics attributed to other factors or just be go unseen. So for the boy who is running around the classroom and, grabbing the pencil because they really want to draw their Pokemon character, right? And having this very gendered, stereotypical ADHD experience, the girl who's sitting next to her friend and talking all the time and wanting to ask all the questions, they're going to be seen as a nuisance. They're not going to also be seen as ADHD within their socialized outlets. Right. I had on every single report card, Skylar loves to make friends and talk wherever she goes. For me, that was actually me stimming. That was part of my Gestalt language processing, needing to get out every single connection I was making in my brain, right? That was me trying to get enough dopamine and stimulation so that I could focus. But for me, I was chatty, smart, and disruptive. And you might see other, and then I was a school counselor for 3 years, or school social worker for 3 years. And I got so many Black, Latino boys in my office for being disruptive and combative when they were autistic boys doing very similar things to their white counterparts. And so me having to advocate very hard because again, because of also the underlying racism, the expectations of boys of color and how they are supposed to show up in, those white normative spaces will then completely obscure the very, to many of us, obvious just traits of ADHD and autism, as well as learning disabilities as well. I want to make sure that we're expanding this conversation. Um, Even something as, um, those smart kids, maybe we would see them otherwise as 2E who, uh, are getting the inference of the conversations, getting snippets here and there. And so they may be in high school and not being able to fully read because of their dyslexia needs are not being met. But they've been able to ace the tests and wow the teachers because otherwise they are doing fine. They're still not actually going up to their own potential should their needs be, if their needs were otherwise being met, but they're doing good for fill in the blank of a subjugated identity. And so that is something that when we're working with parents, also there is oftentimes a lot of concealment, guilt, and shame around these traits because, oh, I could have been better if I could X, or not telling you that maybe there is um, a something like reading, right? Oh, here, just go ahead and read this. Tell me what you think about it. And if you're dyslexic and you've never been identified as dyslexic, then maybe having something that is written in small, serif print on a white background paper, that's going to be, you're asking for a lot more emotional labor. You may be asking for something that's just not possible within what they have. So that's why we need to start looking for and creating a environment of curiosity so that people can start to share the things that not only have gone unnoticed, but oftentimes have been built in with a lot of shame. And then being curious about how is this impacting their pregnancy, birthing, and parenting experience, and also how is this relating to when they see these same traits coming out in their children? How do they understand them? And this is obviously a very big passion interest of mine, but and it takes on the clinician's part doing that deep dive of assumptions. Where am I getting my ideas of autism, ADHD, learning disabilities from? How was this being studied? Who was the intended person within what intersectional identity? And how could this look differently for the person who's in front of me?
I do see commonly, I believe I'm an example of this too. I see people who are from a different culture, or an immigrant, or a minority ethnicity. Their autistic traits are attributed to they're different because they're Black. They're different because they're gifted, or they're different because they immigrated here from this other place. Um, and that also contributes to them not being diagnosed till much later in life. Again, it also contributes to intersectional marginalization.
So oftentimes you'll have double masking or coach switching, right? Being able to survive in a white normative environment. And I use survive very purposely here. Um, we have so many instances of Black, Arab, Latino autistics who have been murdered by police for stimming and being or not understanding instructions, taking directions from those with force and authority very literally, and then being seen as disrespectful. When we're looking at masking and camouflaging, especially if you present as white, there is going to be a lot of trust building, and it is not on us to assume that we are safe. It is on us to show that we are there and curious and interested, and that we are doing our own work, and that I always say, like, if you're working with somebody, with an intersectional identity that you don't maybe have a lot of information about, paying some clinician who holds those identities to understand about the general experience so that you can go back to that client with informed curiosity. So that you are saying, I am not expecting you to teach me about your culture. I am asking you to explain how you interpret your own culture, which are two entirely different questions. What makes sense and what doesn't within your own culture understanding, and what's modeled for you. Oftentimes that's when we start to look at the neurodivergence, because neurodivergence is socially constructed as well. We are diverging from a cultural norm. And so if we are in a white neuronormative society, that's going to look really different from another culture, right? Or in white American neuronormative society is different from even a British neuronormative society. It's going to look really different from a Ugandan neuronormative society. It's going to look different to, my husband is East Los Angeles Mexican, which is it is different from Mexican in a very, very different ways. And so understanding the nuances of how somebody identifies, how they take on their own identity, how they interpret, how their families interpret that identity, to be able to suss out, okay, what is within a normative for your intersectional sense of belonging, and what do you feel separate from? And that is often the seed that we can start to water so that people can understand their own identity, again, from a place of within instead of from the outside.
And
I
I think
also
one part
see
too is as we are, like learning about neurodivergent identities, really thinking about who we're learning from and making sure that we're like, if we're wanting to learn about more about just, say autistic lived experience, making sure that we're, again, like learning from people from a variety of backgrounds, variety of different life experiences of intersections, to be hearing these different experiences and making sure we're not just I don't know, like mainly learning from all like white folks, right?
I also want to highlight how intersectional marginalization impacts quality of care and access to services and support. For example, a Latino autistic mother of an autistic child may join a support group for mothers of autistic kids, and everyone in the group is white. Or do they go to the support group for Latino moms and everyone in the group is Latino and understands that aspect of their experience, but no one has an autistic kid. And in finding medical professionals and therapists, they may feel like again they have to choose between someone who understands my ethnic identity or someone who understands my religious identity, and someone who understands the autistic experience may feel like an impossibility for them. It really highlights how important it is for people to, as clinicians, to be as curious as possible, because many clinicians are saying, yeah, I specialize in the perinatal experience and may not have background in autism. And if you are um, treating human beings, then you're going to have a lot of autistic patients. And then to at least be able to recognize that so you can refer out if you need to, instead of being siloed in that particular area of practice. Black autistic children are 2.6 times more likely to be misdiagnosed than white autistic children, most commonly with the diagnosis of adjustment disorder or conduct disorder.
Yeah, and I think that that really brings up the idea of when we're thinking about like a formal diagnosis, of really thinking about who has access to that and if there are risks to that. Like there's a link here, or not a link, but showing an article from Devin Price here, kind of looking at some different sides of diagnosis. And again, it's really complicated because diagnosis certainly can give access to services. It can give access to benefits sometimes. Um, but again, there's not equal access, like, here with that example that Black autistic children are often being misdiagnosed even when they are, in that process, right? That they don't always come out with the right diagnosis. And there's certainly other groups where that can be more likely as well. And really looking at the nuance around that for some folks, they may not need a formal diagnosis. And it may be more around self-diagnosis, self-recognition, and that is equally valid as well. But really looking at, again, the nuance here around this and what the needs are, and knowing that there are barriers to access as well.
People go to have an assessment done, there's always the risk of misdiagnosis, which can be very harmful. I actually will and tell patients, um, I'd rather you do a self-diagnosis than go get an assessment that is not, I'd rather you not get an assessment at all than get an assessment with someone who really doesn't understand the depth of how autism presents in higher masking, very intelligent, minorities, gender and ethnic minorities.
Mhm.
So there's a lot of evidence that self-diagnosis is pretty accurate. It's never going to be completely accurate. Just like I can make an inaccurate diagnosis of my patient, so can patients make inaccurate diagnoses of themselves. But it is a very, very important because I see patients as experts on themselves, that when
Mhm.
given a lot of information, I do believe that patients are the best source of information in telling me whether a diagnosis truly fits them.
It works within the medical model and understands diagnostics through the medical model and never saw herself as ADHD. So instead, seeing me for OCD and social, socially, social challenges and this, that, right? And it kind of all added up. And at the beginning of our time together, I'm like, you're really looking like a lot of my ADHD clients who look like you and who have the same cultural identity as you. And it was like, nope, 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 that is not me. And now that we've been able to get to a point where she trusts that I see her wholeness and goodness beyond any sort of DSM diagnosis, but instead we have leaned into the neuroidentity model. She's now all of a sudden really open. And so when I said, hey, why don't you go onto TikTok or Instagram and start to look at other creators who identifies ADHD with your religion, with your ethnicity, and being able to start to do that, she started laughing and she said, we used to make fun of people who would come in with a TikTok diagnosis. And now you're telling me to do this, but also it feels right now in a way that it didn't before. So oftentimes we're going to be working with people who don't feel, either because professionally or just within hearing the derision of TikTok diagnosis, they're not going to feel comfortable just listening to other people who have similar experiences of them and their experiences of ADHD. And so sometimes it will take almost, just slicing one layer at a time of trust and commitment and identity building for people to feel like they are have the ability to self-recognize. And so it's on us to encourage that and to also, normalize that, yeah, we do live in a society that is very hierarchical when it comes to pathology diagnoses. And when I'm talking about ADHD or autism or any other neurodivergence, I'm not coming from that place and being able to have those complexities of conversation so that people then can understand what's best for them.
Over some of how females and those raised female tend to be misdiagnosed or diagnosed much later in life. Um, so females and those raised female tend to present as less autistic on the surface, but they experience more internal turmoil and distress. And this is broad, doesn't apply to everyone, but generally females internalize their stress, blame themselves, try to people please. Males tend to act out and externalize distress more. So females who aren't causing a major problem for the teacher are going to fly under the radar. They also tend to have more social motivation and will have will create friendships and will be pretty intense into like a particular peer often, and then somehow that relationship explodes, and so they experience more friendship conflict actually than male autistics, and tend to blame themselves, believing the conflict is always their fault. They tend to mask more effectively. That is, they can hide their autistic traits better. And additionally, when we think about stereotypical female and male gender roles, um, a man can be very direct, assertive, talk about their special interest, and it be much more socially acceptable than for a female to be very direct, assertive, talking about their special interest, being focused on their career. And so our stereotypical female gender roles are less forgiving of autistic traits. Devin Price in Unmasking Autism, Discovering the New Faces of Neurodiversity notes women are not less impacted by their autism. They are just less seen. Bringing up the point that being able to compensate for a challenge or hide the challenge is not the same as not having that challenge. ADHD additionally can mask an autism diagnosis. Often, now I was diagnosed with ADHD at age 6. It was pretty obvious to everyone. I was all over the place, talking nonstop, climbing, impulsive, etc. My formal autism diagnosis did not come to age 40. So the ADHD behaviors are generally the ones that are seen first for a lot of people, but not always. And the ADHD neurotype really seeks a lot of newness and stimulation, and that can sometimes mask the autistic need for routine, familiarity. So um, if you do a dive into what that person is experiencing, you can see how both are at play. For example, with ADHD, I need to learn a new thing about psychiatry or do a new fantasy themed presentation. But I always, and I need to be active and moving, but I want to use the same exact elliptical in the same exact spot at the gym because my body knows what that elliptical feels like. And I want to go to the gym at the same exact time of day because then I know what to expect as part of my routine. ADHDers will tend to be more extroverted, seeking more social outlets, and so not fitting into that autistic stereotype of being introverted and shy. The impulsivity of seeking new relationships can also mask the autistic need for routine and sameness.
Yeah, and we were talking about that many autistic females or people who were raised as females, that the way that they socialize may not be seen as what folks are thinking of as autistic, that the masking may be seen as more effective. Um, but there are still things that come up socially, that can still be really hard and really painful. One thing like I hear from folks talking about of like trying to kind of do this formula, like within a lot of social situations around, okay, like how much information do I share? What is just the right amount? But sometimes still feeling like, oh, like, well, that was too much or that wasn't enough, right? Or there can still be, miscommunications, of course, and that can cause disagreements that may be based on, again, a miscommunication between the two people. It's more of a miss, right? But then it can still cause conflict if there's misunderstanding. Um, and also kind of figuring out, or kind of directness. It's not uncommon, like for autistic girls or women sometimes to kind of be called too direct in some way or another, that something should be softened or assume that like something they said to somebody was intended to be rude, even though it was just meant to be more of a neutral statement. So these interactions it can still be tricky at times. Yeah.
And the executive functioning challenges. Ariel tells us being both intelligent and ADHD what's supposed to be hard is actually easy for me. But what's supposed to be easy is honestly really hard. Like cultivating meaningful relations between merfolk and humans for societal growth, totally. But showing up to an OB-GYN appointment on time, is that even possible?
And this is just a really wonderful image from Sonny Jane Wise that is showing some different executive functions. So we're thinking regulating attention, sense of time, planning and prioritizing, working memory, self-regulation, and you can see some other things here. And when we think about like the perinatal time frame, right? Like at least for some folks, like that it can feel like executive functioning. They kind of had a plan. They kind of have a way of kind of managing things. And then, perinatal period comes in, pregnancy, baby's here, and suddenly there are a ton more things that are taxing executive functioning. There's a ton of stuff to track. There's a lot more appointments. There's a lot of just items to organize. There's a lot of decisions, a lot of researching that goes into that, a lot of like wanting to make, the right decision on different things. And so it can go from a place where it felt like, okay, kind of got things figured out. But then there's just a lot more, and it can feel really overwhelming. Just when there's that switch to like, oh, things are kind of imbalanced, to things really feeling overwhelming, because there are just so many more things, so much that are going to be taxing, that are going to be using those executive functions.
Leads to a lot of new diagnoses of ADHD in the perinatal period.
Mm-hmm.
Ariel tells us, years of internalized ableism made me think I was failing if I needed Eric's help. It took time for me to accept support and accommodation.
Mhm. Yeah, so Ariel and Eric, once Ariel got to a point where she was okay with accepting some support when she worked through some of that internalized ableism with her therapist, they were able to just kind of rebalance some things. They were kind of looking at, like, okay, Eric actually does have the space to maybe track those appointments, to really be kind of looking at the calendar. And maybe that could be something that Ariel doesn't have to be in charge of. And one thing they were really looking at for both of them um, was, even though there's a lot, less time now because caring for especially a new baby is really time consuming. But really looking at how can they still help each other be able to engage in their special interests, and how can they try at least to know that there's that need for restoration, that need for quiet, or that need for rest. And that can be really challenging in that time period just because there's not a lot of time and it's busy. But they're at least keeping that in mind and seeing, when are those times? When are there are some times that maybe Ariel can be looking at her collections, right? Or maybe she's wanting to research one of the items that she has. So maybe having some time for that is going to leave her really at least a little bit refreshed, right? So keeping that in mind as well as a way to support each other and accommodate each other.
Like the section on this slide that emphasizes equity instead of equality. So thinking about, if one partner really doesn't function without sleep compared to the other partner who's more able to function with less sleep, we're going to take that into consideration in dividing tasks instead of trying to make them be even. If one partner has more sensory issues around dirty diapers and the other partner can tolerate it better, then we're going to take that into consideration to make things more equitable, but not equal.
This is also where that cognitive empathy comes in. I recently worked with two people where one of them constantly put themselves into sensory distress because of vacuuming, because they knew that vacuuming is just the absolute worst thing, like household tasks to do. And so they felt kind of called to, everybody is supporting my needs from this. I can do this. I can jump on this grenade for the good of my family. And then when we're talking, their partner was saying, wait, no, but I really like vacuuming. I thought you did too. I didn't want to take that away from you because I knew that this was something that you just seem to always do. And they're like, no, if I could do it, I would just, dust all the time. But I give that to you because that's the thing that I know is like the best thing to do. And they're like, no, I actually hate dusting. I would take vacuuming any day of the week. So sometimes also we have these assumptions. If I hate this is just the worst job and I somehow need to do this to make up for where I'm taking in other areas. So really, again, I feel like it's like the Pee Wee Herman word of the day here is curiosity and putting it out on the table so that way with curiosity, it is so much easier to find equity than it would be otherwise to just rely on assumptions of what are good and bad tasks.
ADHD meds in breast milk. Brief overview. Because Ariel asks, can I breastfeed with my ADHD meds? And this is not a one size fits all answer. It depends on the mom's functioning on and off meds. Certainly, our concern is we want to make sure that moms are eating enough to produce milk. We want to make sure that the babies are eating enough. Generally speaking, we got a lot of great reassuring data on the methylphenidate, most commonly known as Ritalin family. And Adderall does get into breast milk. Estimates of 15%. Does that mean that you cannot breastfeed with it? No. It means that it's a risk benefit discussion that would ideally be done with a perinatal reproductive psychiatrist if possible. Some meds like guanfacine and atomoxetine, we don't have data. That's Strattera. And clonidine, we do avoid that. Okay, because there are higher levels of clonidine in breast milk, and there are some reports of some negative outcomes in infants there. But Ariel says, Ursula told me she's holistic. She's only using natural ingredients. So I should switch to what she has to offer instead of my ADHD medication. We've heard this a lot. Whether a substance is natural or man-made has actually no bearing on whether it's safe, effective, or has side effects. So I'm always encouraging my patients. A truly holistic approach means we're utilizing all resources, exercise, meaningful activities, therapy, and medication. And we want to emphasize medications where we have a large body of data, safety data behind them, if at all possible. Ursula says, oh, let me go over. I don't know if I left out the slide on ADHD meds and pregnancy, by the way, unfortunately. But essentially, that decision is going to be complex and individual based. We have a lot of great reassuring data on ADHD medication during pregnancy. Now, it used to be that all moms were being told to get off their ADHD medication during pregnancy. And we're finding there's definite risk with that, risk of unemployment, risk of car accidents, higher rates of relationship conflict. So our newer data, we found that the original findings of some birth defects were specifically in studies where patients were abusing and taking extremely high doses of ADHD medication. When patients are taking ADHD medication as prescribed, we have pretty good reassuring safety data. We do need to monitor pregnant women taking stimulants more closely for hypertension and to make sure that they're gaining enough weight since stimulants decrease appetite. But you can take them while pregnant, ideally also under the experience of a perinatal psychiatrist. Ursula tells Ariel, you're a full-grown adult, not a child. ADHD meds are just a crutch for little kids who can't manage themselves yet. You just need to get it together. Treating ADHD in the perinatal period, no one right answer for everyone. I was just discussing this, but I didn't go to the right slide. Sorry. Here are the studies on really reassuring data about ADHD medication during pregnancy.
and specifically for breastfeeding methylphenidate data. A really great website is Mother to Baby, um, and the Massachusetts General website for women's mental health. So, in figuring out what Ariel specifically wants to do with her meds, first we ask questions. First question: how have you functioned in the past without the use of medication? She says, I couldn't find any of my who's its and what's its. I forgot my dad's concert. And honestly, the hardest part was when I was fighting with Eric a lot because I let him down. What about impulsive and risky behaviors when you're off your medicine? Well, I made a really bad deal with the sea witch. Oh, and I forgot pants. How does your ADHD impact your safety driving? And so Ariel makes the decision to continue her ADHD medication, specifically her stimulant, because that has a really big impact on her relationships and her driving safety. However, she decides to discontinue her guanfacine medication. Guanfacine does not have a large body of safety data in pregnancy. Um, and she believes that that is less integral to her functioning and decides instead to pursue different therapies to better address her PTSD. That being said, if Ariel said that the guanfacine was integral to her functioning and mental health, we would have her continue it, even with less data, because we always prioritize the mental health wellness of the mom. If the mom is mentally healthy, we have a better chance of a healthy baby. Maternal psychiatric illness has a significant impact on fetal development and a significant impact on early childhood attachment, which can then impact a child's ability to form really healthy relationships on an ongoing basis. So this is really a very careful and nuanced risk-benefit discussion that's individual for each specific individual. There isn't one right answer for everybody.
And
She tells
also
us,
I was just going to say another aspect of that is also
go ahead,
oftentimes
Skylar.
educating the partner. Oh, can you hear me or no?
Yes,
Okay.
we can hear you. Go ahead.
So is going to be another important thing is to educate the partner, because oftentimes the partners will also have stigma and biases about medication and will want the person to stop. And so while we may have our own feelings about bodily autonomy of the birthing person and what the appropriate influence their partner has, we also live in the real world. And so being able to also empower our clients to advocate for themselves and also to co-navigate this experience so that the partner does feel is able to not just tolerate or pretend it doesn't exist, but also to indeed support their partner if they have misgivings originally in continuing their medication for a healthy, happy pregnancy, or at least not a miserable
And I mean,
pregnancy.
let's face it, um, if a pregnant woman is getting messaging from her spouse or her parent or other parents around her that she's doing something wrong by taking psychiatric medication while pregnant, that's going to make her want to stop her medicine, and it's going to contribute to conflict and shame. So really working to educate the whole family. I'm glad that Skylar brought that point up. Um, I also encourage my patients about what pieces of information they should take seriously and what sources of information they should take seriously. For example, I can show them the most up-to-date information from the Massachusetts General Hospital Women's Mental Health website and articles, and they're well-meaning but uninformed pharmacist who's like, oh, wait, you shouldn't be taking this in pregnancy. It's category whatever, whatever, is not where they should be getting their information about their medications. Onward from that. Thanks. Ariel tells us, honestly, it's not the communication differences or executive functioning challenges of ADHD and autism that impact my parenting and quality of life the most. It's the chronic health issues and my medical professionals not believing me, thinking it's all anxiety. I have a lot of chronic ill health issues and lived experience there myself: fibromyalgia, hypermobility spectrum disorder, dysautonomia, a lot of autoimmune disorders. And often medical professionals have a knee jerk. Well, I shouldn't say often. I will give them the benefit of the doubt. Some medical professionals may have a knee jerk. Oh, this symptom doesn't make sense, so it must not exist response to patients who do not understand exactly what's causing their symptoms of chronic fatigue or chronic pain. And addressing this, helping these mothers make peace with physical limitations is really important too.
The same body. It's amazing, Stacey. But and also just again, a lot of times something like hypermobility spectrum disorder, and that's a very different pregnancy experience. That's
Yes.
much harder on the body. There's a lot more expense. Also, one of the things that I work with a lot with my clients is not just that maybe I'm not able to do what I need to do around the house to pull my load, but also I am like, to keep my body together so I can walk, I'm having to go to the chiropractor every single week. And this is taking
Mhm.
such a huge financial toll from our family as well. And so being able to look at that aspect of it and kind of this idea of like, other people are handling pregnancy so much better than I am. And because of this, I am putting an undue burden on my family is very real. And then also how they advocate for their bodies with their medical professionals. I can tell you recently, I was actually listened to about my vision differences and I cried with the ophthalmologist because I wasn't made to feel crazy for the first time ever. I felt like for something that was just something strange that I didn't quite have the words to even explain because it's never been modeled for me.
Yeah.
And so expecting not to be taken seriously. And so then just trying to hide symptoms, it's almost like reverse, I forgot what the DSM-5 calls it now, but right, kind of right, but what hypochondria was like, I feel like I had reversed that where I would really minimize my symptoms because it was so strange and out of the ordinary or something I'd never even heard of before. And it turned out they really were something that should have been paid attention to. And I put my health and well-being at risk for not speaking up because I just assumed that I would not be believed and that there was nothing to be done about it anyway.
Mhm. Not to mention differences in interoception, that is picking up on internal body cues, hunger, thirst, pain, can lead to many autistics not seeking medical care until things are really serious. And I also I resonate with what you said a lot, Skylar. I'll share that um, a major relationship accommodation that my husband offers me is he manages my medical appointment schedule for me. So he schedules my appointments with physical therapy, with orthopedics, with rheumatology, with immunology and allergy, and with the chiropractor. It's because his um, executive functioning for that and just tolerance of talking to people on the phone way surpasses my tolerance for that. And it's easy to feel like a burden in these situations, but really this is an equitable but not equal relationship with my neurodivergent body. Right. The ADHD neurotype, not just uh, it's not impacting the brain, but impacts the entire body. All of these different medical conditions are occurring in much higher rates in both autistic and ADHD bodies. The invalidation and dismissal by healthcare professionals can be really significant. Ariel said, I have a binder of my medical history for my appointments, made a spreadsheet of my symptoms to help my doctor. I offer just a few helpful New England Journal of Medicine meta-analyses regarding my top 3 hypotheses. And Eric told me I came on too strong because apparently presenting too much evidence makes the doctor not believe you. And they told me just increase my anxiety meds because clearly this was an anxious individual. So invalidation and dismissal by healthcare professionals because we have complex healthcare issues that people don't understand. And it's harder for us to communicate most effectively in the neurotypical hierarchy with medical professionals is a big deal. Additionally, autistic and ADHD people have higher risks of birth trauma and medical trauma due to their negative experiences with the healthcare system, with hospitals, etc. All Brains Belong website is a great resource that has a medical guide for and it has a lot of hyperlinks, which shows you research articles for how different conditions, connective tissue, sleep, digestion, allergy, immune, cardiovascular, are associated with neurodivergence. In summary, lead with curiosity. Neurotypical blinders can at times when a neurotypical person is trying to be helpful to an autistic person, it can feel like a bird trying to save a fish from drowning. People can mean very well when they give advice. And without that understanding of the different perspective, different experience, and different needs of the autistic individual, this can cause harm. For example, not treating autistic burnout like depression. We don't treat autistic burnout because it involves intense emotional and sensory overwhelm and then fatigue and exhaustion. If we give that person behavioral activation tasks like we would someone who is depressed, we could make them worse. Ariel finally gave herself permission to do motherhood her way. Sensory-friendly clothes, special time to catalog her thingamabobs, and engaging in her Save the Oceans project. Now I collect empowering information as well as who's its and what's its. So I think it's really great to give people a lot of sources to their own self-exploration and to connect people to autistic and ADHD role models. I remember Skylar mentioned TikTok used as a resource. I use Divergent Conversations podcast, the Autistic Culture podcast, so that people have examples of that mirror their experience. As Ursula says, some women don't appreciate how powerful their voice is until they've been silenced. Thank you so much for giving us autistics a voice. Again, I'm Dr. Stacey Greeter. You can find my website, StaceyGreeterMD.com, spelled StaceyGreeterMD.com. And my YouTube channel is at Stacey Greeter MD. Thanks so much. And then Jane.
And again, I'm Jane. Oh, sorry. And again, I'm Jane Kosloff. An easiest way to find me is just through my website, which is counselingwithjane.com.
Skylar Ibarra, and I am LinaraTherapy.com. I also various trainings and consultations. Jane and I offer a 6-month closed cohort consultation group with the next one opening in September that we are very excited about. So all of that and more can be found at my website.